Cryoglobulinemia is an uncommon condition characterized by the presence of cryoprecipitable immunocomplexes in circulation, leading to clinical symptoms like purpura, muscle weakness, and joint pain. Specifically, mixed cryoglobulinemia involves the formation of these complexes due to rheumatoid factors, mainly IgM and occasionally IgG or IgA. Previously, hepatitis C was a common cause of mixed cryoglobulinemia, as the chronic infection of hepatitis C triggered immune responses that resulted in cryoglobulin formation. However, the emergence of direct-acting antivirals for hepatitis C treatment has shifted the landscape, with autoimmune and lymphoproliferative disorders becoming more prominent etiological factors for mixed cryoglobulinemia. In this clinical vignette, we present the case of a 67-year-old female with past medical history of cirrhosis secondary to hepatitis C, osteoporosis, hypertension, and status post-percutaneous cholecystostomy 1 month ago, who presented with generalized weakness, nausea, as well as severe generalized joint pain predominantly in patellar and glenohumeral joint as well as cervical spine. Remarkably, on the physical exam, the patient was found to be febrile, tachycardic, hypotensive. Also, the patient was found to have icteric conjunctiva and restricted range of motion in neck, as well as tenderness to palpation in knees, cervical spine, and glenohumeral joints. Also, ecchymosis were present on both arms. Abdomen was distended, however, abdomen was not tender, and also the site of percutaneous drainage was without any signs of infection. On further laboratory workup, the patient was found to have leukocytosis and neutrophilia, as well as significant elevation of inflammatory markers such as CRP and lactate. The patient was found to have clinical data suggesting prerenal AKI. As well, abdominal CT showed liver with cirrhotic morphology, as well as multiple left upper quadrant varices consistent with portal hypertension. Hepatitis profile was positive for hepatitis C at this moment. The patient was admitted to internal medicine floors due to severe sepsis, likely from bloodstream infection. The patient was started on IV fluids as well as on albumin infusions to maintain blood pressures. The patient started on broad-spectrum antibiotics such as vancomycin and piperacillin tazobactam. The patient was also started on 5 milligrams of midodrine. Prerenal AKI improved after 24 hours of therapy, and also the patient remained afebrile from this point. And after 72 hours, the patient was successfully weaned for midodrine and maintained adequate systolic blood pressures. WBC count and CRP and neutrophil count downtrended to basal. However, the patient continued with generalized joint pain with slight improvement with acetaminophen. The patient presented primordially cervical spine pain as well as knee and glenohumeral joint pain. The patient underwent cervical spine CT and knee X-ray that demonstrated the presence of moderate spondylosis and ruled out the presence of osteoarthritis. As the patient had previous history of hepatitis C infection, we started approach for mixed cryoglobulinemia and other autoimmune diseases for ruling out the cause of joint pain. This examination covered the presence of hypocomplementemia and positive results for rheumatoid factors including IgA, IgM, and IgG, as well as positive cryoglobulin agglutination, confirming the diagnosis of mixed cryoglobulinemia. The patient was discharged and sent to outpatient rheumatology for further management. This case emphasizes the importance of considering mixed cryoglobulinemia in chronic hepatitis C patients displaying fatigue and joint pain, even in the absence of the traditional Meltzer's triad. Moreover, this case underscores the dual benefits of antiviral treatment for hepatitis C in individuals with mixed cryoglobulinemia by achieving both viral eradication and by alleviating cryoglobulinemia-related symptoms.